First of all is committee members on the neutral testimony. There was one of the files on David Jordan that would not open up online, but it has been emailed to you to your state email account. So just if you go looking for it, that's where you're going to find it and be able to open it. They're having difficulty online opening it. So I'd like to start out with Scott Abbott. If you'd kind of go over 2206, I'd appreciate it.
Thank you, Madam Chair, and good afternoon, committee. House Bill 2206 was sponsored by this committee. This is the telemedicine bill. It would make a couple of amendments to the Kansas Telemedicine Act that was first enacted a few years ago, relating to definitions in the Telemedicine Act and provisions for referral to specialists and coordination of care. So the first couple of amendments are to definitions in the Telemedicine Act. The first is in distance site, to add some specification that a distance site may be an unlicensed or private location where the healthcare provider is located. It would also amend the definition of originating site to specify that the originating site may be a domicile or other non-public location where the patient is located. Would also add a little bit of specificity to the definition of telemedicine, to the technology that is used for telemedicine, and provide that it used technology utilizing medical devices, and would further specify that telemedicine, the technology platform would facilitate the verbal consent in addition to all of the other aspects of care that are already delineated under the Kansas Telemedicine Act. The next set of changes are in Section 2 of the bill on page 2. The first is to amend the provision that currently states that a telemedicine may be used to establish a valid provider-patient relationship, and would add that telemedicine may be used to establish referral to specialty services to the extent that those services are consistent with the applicable standard of care. The last change is to add a care coordination type of provision. This is the new paragraph 3 near the bottom of page 2 of the bill. Provides that for a patient who consents and who has a medical home or a primary care or other treating physician, a care coordinator or other Kansas-based healthcare provider, the telemedicine provider would coordinate care to the greatest extent possible with that Kansas healthcare provider with the patient's consent, and to the extent that it's not otherwise prohibited by any other provision of law. The bill would take effect upon publication in the statute book, so July 1 of this year if it were passed. And I would be happy to answer any questions.
Thank you, Scott. Are there questions for Revisor Abbott? All right. Seeing none, committee, we'll go ahead and open up our hearings. Thank you, Scott, for that. And first up, I have Stuart Little with Little Government Affairs. Welcome to committee, Stuart.
Thank you, Madam Chair. My name is Stuart Little. I'm here on behalf of Little Government Relations, and just contextually, Madam Chair, before I get to my testimony, I might just mention a bit about how this bill kind of got here, if you're interested in. So there were a group of provider organizations that were part of a survey that was conducted by the United Methodist Health Ministry last summer with regard to telemedicine. And there were several of us who participated in that process, and we were having the survey, and we're having conversations about drafting a telemedicine bill and what it would look like. And so what it evolved into essentially was a consensus working group where we put together some of the basic ideas that everybody could kind of agree on that were non-controversial. I mean, there's not that there's things to be argued about any of these points, and I certainly don't disagree with that, but that we would put together a bill that had some of those components all together in one bill, that then anything else could go from that. And essentially some of it was pragmatic in terms of if we're all going to be drafting the same bills that are doing the exact same thing, we want to try to pull something together. The bill that you have in front of you contains components that everybody said, yes, we're fine with this in the bill. but this by no way does it suggest that everybody agrees and endorses everything in the bill. People are going to come up and talk about different components of it, things they want to add that there wasn't consensus and those kind of things. So, but for the record, the folks that took part in our conversations: Kansas Medical Society, Hospital Association, Association of Community Mental Health Centers, family physicians, pediatricians, doctors of osteopathy, and somebody help me out. Who else I would have? Behavioral Health Association, Community Care Network of Kansas. I believe that's all of them. So informal, put together what we'd agreed to at least have a bill that contained components. So I just wanted you to make clear about that. That's how this ended up in front of you. And Madam Chair, I appreciate your indulgence in allowing me to describe that, but also for getting the bill drafted. I'm here on behalf to speak in particular with one of the groups, which is the Behavioral Health Association of Kansas, and talk about how telemedicine has benefited the substance use disorder treatment field, behavioral health services, and our support for the changes that came from the state and the federal level, including the executive orders and emergency declarations that provided for all of us the ability to make use of telemedicine during the pandemic. What was important, was critical, and I think everybody has our own areas of interest, but behavioral health was significant, and in particular substance use disorder issues. I think anybody who followed along with funny memes or humorous ideas about how people were filling their pandemic time certainly suggests that there are issues that we will have to deal with. With regard to addictions and those kinds of behaviors. But one of the things that was important in the behavioral health field was that the stresses of the pandemic were stimulating a great deal of folks reaching out, but also making it difficult for folks to access services, and telemedicine was a great means to provide services, to keep ongoing services with clients, but also to respond to outreach. And you'll hear from folks in mental health centers that those same kinds of components in the community care network that started having greater input from behavioral health services. There were also telemedicine reduced some barriers, whether those were geography or income and your ability to make it to a treatment program and get services and those kind of things. Telemedicine addressed that. In the substance use disorder treatment side, you had everything from individual therapy to group therapy. How do you do that when you're in a quarantine and not supposed to be gathering? How do you do inpatient residential services? How do you do that? If you have somebody test positive, you got to close down your facility. If you have a clinician that tests positive or has come in contact and has to isolate, they have to work from home. Telemedicine, the changes that were implemented allowed all of those things to happen. We support the components in the bill. We are interested in pursuing issues of payment parity, of making some changes with regard to telemedicine. They're all listed on the second page of my testimony. And I think one of the things that I want to circle back to, which has been part of the conversation that we took engaged in to draft this bill, but also listening to some of the conversations in the Can Care Oversight Committee, the Mental Health Reform Commission, and the work that they've been doing, and that especially the task force, the subcommittee on behavioral health, is that telemedicine in the behavioral health field is never going to replace that face-to-face relationship. It's an additional tool, a component for people who are isolated, who don't have access to get to services or the capacity to do that. And it's always going to be required to be adhering to those standards of care that we all have to follow. So that's kind of our perspective from the behavioral health side on the bill. I'd be happy to stand for questions at the appropriate time.
All right, thank you, Stuart. And I think what we'll do, committees, we'll take questions at the end after we get through everybody, if that'll be all right. And committee, we're going to try to hold everything to about 3 minutes. I did announce that before Stuart got up there, so if he got 4, he got lucky. And then he'll owe me now. Maybe a cup of coffee or something, I don't know. He did well. He did well. Huh? No, that's another topic, another committee. All right, next up I have Audrey Dunkel, Vice President of Government Affairs with the Kansas Hospital Association. Welcome to committee, Audrey.
Thank you, Madam Chairman and members of the committee. As the chairman said, my name is Audrey Dunkel, and I'm the Vice President for Government Relations at the Kansas Hospital Association. We were part of the larger group that worked on this piece of legislation, and we really appreciate Stuart Little pulling that group together to see where we could agree on things that could change or improve long-term in telemedicine. But as we look at this piece of legislation, we think it's a good start, but there are some things that we would like to see added. Not surprisingly, first on our list is payment parity. 3 years ago, we had this conversation about what telemedicine should look like. We convened a large group of people. In fact, Madam Chairman, you convened that large group of people to sit down and have a conversation about what we might do to improve the landscape in the state of Kansas. What we ended up with was the legislation that this is based on, and we ended up with coverage parity, which we appreciated. But I will tell you, as a group, Kansas hospitals walked away from that conversation saying, well, payment parity was our priority. We're going to see how it goes with coverage parity, and we're going to come back and talk to you. And today is the day that we come back and talk to you and say, coverage parity is just not enough. We have seen the use of telemedicine skyrocket with COVID-19, and it should. It protected patients. It gave them access to care when otherwise they would not have access to care. It gave people who did not want to travel because of COVID access to care in communities that were far away in order to maintain their health during this situation. We do appreciate that the insurance companies have been providing payment parity during the pandemic. They recognize the value of telemedicine and continue to pay parity rates. However, I will tell you, as we near each end of the pandemic emergency order, we receive a new letter that says, by the way, your rates are going to go back down at the end of the emergency order. And this is the concern that we continue to have. Second on our list of adjustments that we would like to see to this piece of legislation is language that allows providers to use the platform of their choice. You're probably going to hear from several providers that use platforms like Teladoc and Amwell. But keep in mind that most healthcare providers that provide telemedicine have invested in a lot of technology and equipment, and instead of making them spend more money to make those changes, we would like them to have the freedom to use the platform they're currently using. Third and last is, as you look at the language in this legislation, there is a little bit of a tweak in the language related to where a beneficiary might be, where the patient might be. The language currently says in a non-public place, but as we continue to review that language as the site, we think that it needs to be the site of the patient's choosing, because we don't want to create a situation where the provider has to guarantee that the patient is in a non-public place, because we don't have any way to do that via telemedicine. So thank you very much for your time, Madam Chairman and members of the committee, and I'll be available for questions when you have them. Thank you.
Thank you, Audrey. Next, I have Chris Wilson, Vice President of Integration Innovation, University of Kansas Health System.
Good afternoon, Chairwoman Landwehr, Vice Chairman Epley, Ranking Member Parker. My name is Chris Wilson. I'm the Vice President for System Integration Innovation at the University of Kansas Health System. And thank you for the opportunity today to speak on HB 2206. In the past, the University of Kansas Health System has provided telemedicine services on a limited capacity to patients across the state of Kansas. During the COVID-19 pandemic, it became clear patients needed not only access to care, but a continuum of care, which allowed them to receive services in their home in order to remain safe and healthy. To that end, the University of Kansas Health System accelerated our plans for the rollout of comprehensive telemedicine to patients across our state. Prior to March 2020, the health system provided less than 100 telemedicine visits per month. At our peak, over 35,000 telemedicine visits were executed in 1 month, and we continue to see no less than 16,500 telemedicine visits per month. According to one recent national survey, pre-COVID-19, less than 1% of visits were delivered virtually. In April 2020, across all the participants in that survey, total visit volumes dropped 31% from February levels, and 47% of those visits were virtual. Total visit volume stabilized over the summer, and in August, 19% of visits were still occurring virtually. The same national survey identified inadequate reimbursement as the top barrier pre-COVID, 84% identified that item, and reimbursement as the top barrier going forward, 64% identified it there. Telemedicine has allowed our physicians to continue to provide patient services both in the hospital and medical offices when on quarantine due to COVID-19 exposure. At a time when staffing was critically important, we were able to carry our mission to provide services in our emergency department, our ICU, and our provider offices. We see this capability as something we would like to continue to utilize for our patients or physicians who are incapable of traveling due to inclement weather, allowing them to keep their appointments without rescheduling or further delaying a visit. We understand other provider groups have come together to discuss the issue of telemedicine and agree with the statement of the Kansas Hospital Association. In order for telemedicine to remain a viable service, we support the inclusion of payment parity as part of the Telemedicine Act. Telemedicine is not going away. Our patients expect this service to continue long past the end of COVID-19. We have witnessed our patient satisfaction with telemedicine services continue to rise. It is currently at 76th percentile, up 16 percentile points over the last 3 months. Under the current emergency declaration, telemedicine visits are reimbursed at the same rate as an in-person visit. However, we know this is unlikely to continue without the support of payment parity. Numerous times during the pandemic, with the expiration of the emergency declaration on the horizon, we were notified by private insurers that they would discontinue the reimbursement at the in-person rate. KHA is correct. Without payment parity, this shift will make it impossible for hospitals to continue to subsidize telemedicine when it is in high demand by Kansans. In addition, we support the effort to guarantee a provider the ability to continue to use their existing platform within their hospital or physician organization for the delivery of telemedicine services without incurring additional fees or equipment costs as part of the platform required by insurers. There are well-established federal standards that address technology requirements, especially regarding privacy and the security of IT systems used in telehealth. Thank you for the opportunity to appear before you today, and I'm available to answer questions at the appropriate time.
All right, thank you very much. Next, I have Dr. Philip Newland, Ascension Medical Group, via Christie.
Yes, I'm Phil Newland. I'm a practicing pediatrician and chief medical officer for Ascension Medical Group in Wichita. Madam Chair and HHS committee, thank you for giving me the chance to also speak supporting the bill 2206. So Ascension via Christie is the largest health system in South Central Kansas, and Ascension Health is a very large leading nonprofit in our country. And we have as part of our mission to serve the poor and vulnerable, but oftentimes we fail to realize the vulnerable is not just those impoverished, but also the medically fragile. And our pandemic has brought to light some of the challenges of them receiving care in this setting. And we are very thankful for the release from some of the regulatory burdens that were in place prior to COVID that impaired our ability to provide telemedicine. We as an organization, and I believe our state, wants to be viewed as an innovative entity when it comes to healthcare delivery to provide excellence in care to all, including our rural counties where access may best be achieved for many specialties through telemedicine options. And we have seen the benefit during COVID of our ability to give primary care, specialty care, and behavioral health care, even such things as remote patient monitoring. The benefits of the freedom from some of the issues of site of origin or the different platforms and the financial parity has been great during this time. I would like to personally present some data that we have seen in our organization in light of the potential concern of telemedicine replacing the long-standing relationship between a patient and their physician, and the desire we have to have this as a tool in our tool belt, not to replace the face-to-face visits. Prior to COVID, we had very few telemedicine visits. And during the shelter at home, we peaked at about 4,000 visits in a month. What we are seeing now is a trend down to about 1,000 visits of about the 35,000 visits a month that we have within Ascension Medical Group via Christie. So it is a small percent, but a valuable percent. And what I think that speaks to is the ability to right size using telemedicine to maintain and actually enhance the long-term relationship between a physician and a patient, which we know ultimately improves quality and improves outcomes and helps manage costs best when healthcare is done in a robust relationship.
Dr. Newland,
So
you have 30 seconds to wrap
I
up.
would speak again in support of the KHA bill and would also speak in support of these potential addendums towards payment parity and towards platform parity as a long-term solution to help telemedicine find its right place in the delivery of healthcare in Kansas. So thank you very much, and I'll be open to questions when the time is right.
Thank you very much, Doctor. Next, I have Michelle Ponce with the Association of Community Mental Health Centers. I'm glad he finally figured out the right person to send a committee to visit with us. Welcome.
Thank you. Madam Chair and members of the committee, my name is Michelle Ponce. I am the Associate Director of the Association of Community Mental Health Centers of Kansas. We represent all 26 licensed community mental health centers across the state who provide behavioral health services in all 105 counties. Community mental health centers provide services to all Kansans needing them, regardless of ability to pay, and this makes our community mental health system the safety net for Kansans with behavioral health needs. We appreciate the opportunity to testify in support of House Bill 2206 to update the Kansas Telemedicine Act. In areas of rural and frontier Kansas, telemedicine has been used successfully in behavioral health for nearly 2 decades. Gaps such as broadband and technology hardware have historically been a challenge. During the pandemic in particular, mental health centers have been actively engaged in planning and developing policies designed to keep staff and clients safe and have used telehealth to ensure access to care, to protect the health of patients and their staff, to maintain those connections with patients and minimize the effects of social isolation, and to ensure the financial stability and sustainability of the mental health centers who are already experiencing economic impact of the current crisis and need to be reimbursed for the services they provide. During this time, the Centers for Medicare and Medicaid Services, or CMS, have allowed more flexibility in treating patients than ever before, including the use of audio or telephone only, which has been a significant enhancement for us, helping to overcome some of those longstanding challenges encountered in rural areas. And the ability to use telemedicine has helped in urban areas as well. Last spring, at the beginning of the pandemic, CMHCs were providing nearly all services via telehealth. Now, even though they've returned to some level of in-person service delivery, telehealth continues to be an important part of the service delivery array. Anecdotally, the centers have reported to us that due to telehealth, they've seen an increase in their kept appointments, that telehealth has helped to overcome access barriers such as lack of transportation or childcare. And in addition, some staff and patients remain apprehensive about returning to traditional face-to-face services, and telehealth helps to ensure continuity of care in these situations. Consequently, our association requests that CMS allowances be allowed in Kansas for as long as possible for behavioral health. And at the appropriate time, we would ask the committee to consider an amendment that in essence just states that all processes, procedures, and reimbursement rates that are currently provided by CMS will continue to be allowed in Kansas for as long as CMS allows. And we provided some example language in our testimony. Thank you for the opportunity to be here before the committee today, and I will stand for questions at the appropriate time.
Thank you very much. Appreciate it, Michelle. Next, I have Todd Fletcher, Executive Director of the Kansas Optometric Association. Welcome to committee, Todd.
Good afternoon. My name is Todd Fletcher. I'm the Executive Director of the Optometric Association, representing optometrists across the state of Kansas. Appreciate the opportunity to appear before you today on 2206. It's a little weird that we're testifying on a telemedicine bill. When you think about an optometrist, you don't think about them doing teleoptometry. And I would agree. 5 years ago, I'd probably say the same thing. Because a comprehensive exam can't be done via telemedicine because it doesn't meet standard of care in Kansas. However, there are certain procedures that they do via telemedicine, particularly triaging, and that came to light really through the pandemic, where they actually were taking care of patients and allowing them to be seen to determine whether they needed to go straight to the ER, whether they needed to be referred to specialty or in the office in a timely manner. So telemedicine does touch on optometry, and I think that's why I'm here today to talk to you about it. We are supportive of the language in 2206. We appreciate the opportunity to have the language shared with us and to offer our feedback on it. As we go forward, I think it's important to make sure that standard of care is followed, that no matter how care is delivered, that it meets appropriate standard of care, and that However, the care is delivered by whatever healthcare providers that the appropriate licensing board has oversight over that entity. There is some confusion right now with the current telemedicine statute. We were actually involved in that bill a number of years ago. Our state board of examiners is questioning whether or not optometrists are allowed to provide telemedicine services outside of the COVID pandemic. Because they're not specifically outlined in the bill. Our interpretation is that they're okay to do it as long as they're following under the scope of their license. They just may not get reimbursed by insurance for it, but the state board actually is questioning that. So we were just asking for some clarification potentially to make sure that healthcare providers that are able to provide telemedicine are listed and then appropriate oversight of their state licensing agency. So with that, I would stand for questions at the appropriate time.
Thank you very much, Todd. I appreciate it. Next, I have Larry Ann Brown on behalf of Teladoc Health. Okay, we had you down as a proponent. Would you mind just waiting and I'll bring you back up on the neutral list? Is that all right? All right, then I have Amy Campbell, Kansas Mental Health Coalition.
Thank you, Madam Chair. Michelle basically delivered my testimony, so I will not repeat it. I would call your attention to the use of voice-only services within behavioral health, and that is a concern that it's not allowed under the bill. Thank you, Madam Chair.
What did you say that was, the use?
Voice-only.
All right, thank you. Next, I have Denise Seisman, Community Care Network of Kansas. Welcome to committee, Denise.
Chair Landwehr and committee members, thank you for the opportunity to express our support for House Bill 2206. I am Denise Seisman, the CEO of Community Care Network of Kansas. We represent a network of health centers and other community-based clinics that specialize in serving our most vulnerable Kansans. These clinics have a common goal: to assure equitable access to high-quality health care. And with that goal, they're often faced with helping to reduce barriers to care. But almost a year ago, a new barrier emerged, one that was very significant and perhaps our biggest barrier to accessing care ever, and that was COVID-19. It resulted in delaying wellness visits, checkups, follow-up visits for chronic conditions, and other types of routine and non-emergent care. In mid-April, in-person visits to community care clinics were down almost 70%. Clearly, something needed to be done to make sure that Kansans could take care of their health, and telehealth was their solution, was our solution. Thanks to efforts at the federal and state levels, providers were given flexibility to implement telehealth, and the public health emergency actually accelerated this model of care delivery. Within a few weeks after COVID arriving in Kansas, 100% of Kansas health centers were providing telemedicine and telebehavioral health services. They worked with patients via video, telephone, and online. As a percentage of all visits, telehealth sessions were as high as 80% at certain health centers during April and May. Even when the public health emergency is over, telehealth will remain a valuable tool. Telehealth works just as well to keep providers and patients safe as it does to help Kansans who live in remote areas, to help Kansans who have transportation issues, to help Kansans who cannot take time off work, or to help Kansans who simply prefer the virtual format. We support House Bill 2206 as a telehealth policies that were implemented in response to the public health emergency make sense to continue. We urge this committee to move the legislation to the House floor for their adoption and approval. Thank you for your consideration, and I stand for questions at the appropriate time.
Thank you, Denise. I appreciate that. Was there anyone else that I did not call on that had thought they were listed as a proponent? All right, seeing none. Committee, you will also note that we have written-only testimony by Morgan Walker, Director of Telemedicine, Children's Mercy Hospital, Kansas City. Scott Wood, Vice President for Physician Network, Advent Health Mid-America Region. Dr. Dina Hubbard, Public Policy Chair, Kansas Chapter, American Academy of Pediatrics. Rachel Marsh, CEO, Children's Alliance of Kansas. And Becky Fast, Executive Director, National Association of Social Workers. Next, I have the list of neutral conferees, so first I'll call up is Larry Ann Brown on behalf of Teladoc. We'll try this again. I think you just wanted your name called twice. That's what happened.
Thank you, Madam Chairman. I apologize. I just noticed the heading on my testimony is incorrect. It should be we're neutral. I am Larry Ann Brown. I'm here today on behalf of Teladoc Health. Teladoc supports telemedicine, but we actually have some questions about the drafting of the bill. And we may have some suggestions that might make the bill better, and at some point in time, we'd like the opportunity just to continue to talk about it. Teladoc Health is the world's largest telehealth company. We have more than 2,400 employees, and we deliver care to over 175 countries and more than 40 languages. We partner with employers, hospitals, and health systems, and we have partner with more than 50 health plans in all 50 states and the District of Columbia. We provide more than 40% of the Fortune 500 employers, as well as thousands of small businesses, labor unions, and public sector employees. They offer Teladoc Health Services virtual care to their employees, and we appreciate the business that we do with them. We're very much in support of advancing telemedicine technology and the opportunities in Kansas to utilize telehealth. In fact, Teladoc Health has been very active in the Kansas Legislature for many years and is very interested and happy to be a part of evolving telemedicine policy. We simply request the committee allow us time to continue to work with the proponents, drafters, and other interested parties in the bill. I would like to point out just a couple of questions that we have with the bill. It may just be a simple drafting error, but I think it needs to be addressed. It would be on page 1, line 27, where it adds the word utilizing medical devices. When reading this section, it appears to me that it says telemedicine should be provided only by utilizing medical devices. I don't believe that's the intent of the proponents of the bill, but that means a person could not even use their laptop to have a telemedicine visit. In addition, we have no idea what section 3 on page 2, starting on line 27, means, and we certainly don't understand what the words meaning to the greatest extent possible. The section above, which is section 2A, already requires, and as long as the patient consents, that the healthcare providing telemedicine services should send a report about the telemedicine treatment that's been provided within 3 business days to the patient's primary care physician or other treating physician. We believe this entire section seems redundant and unnecessary. I'd also like to reserve comments on other proposed amendments, but keep in mind telemedicine is supposed to be a tool to help reduce cost of healthcare and enhance our current healthcare system, not replace it. Legislators are going to want to be careful that they don't take action that will have unintended consequences. I might also point out that I do believe that audio only between a patient and a provider is currently allowed under the Telemedicine Act, and just wanted to clarify that. And I'll be happy to stand for questions.
Thank you, Larry Ann. Next, I have Camille Snyder, President, Kansas Chapter, American Physical Therapy Association.
Hi, yes, on behalf of the Kansas State Chapter of the American Physical Therapy Association, thank you so much for the opportunity to testify on House Bill 2206. APTA Kansas recognizes the great opportunity that telemedicine offers, especially during these tough times. As strong advocates of telemedicine, we are seeking an amendment to House Bill 2206 to recognize our profession with the other healthcare providers in this bill. Until that time, we unfortunately remain neutral on the bill. Our previous APTA Kansas President, Susie Harms, testified in 2017 that we were neutral regarding House Bill 2512, which addressed telemedicine coverage parity. Harms noted that we would certainly be a strong proponent for this bill if it recognized all licensed healthcare providers, including physical therapists and physical therapist assistants. With COVID-19, physical therapists have been utilizing telemedicine significantly this past year. Telemedicine does not change our standards of professional care. It is merely a modality to execute treatments, including fall risk assessments, environmental physical safety in the home, injury management and prevention, as well as exercise prescription in the frail or subacute injury populations. Working in an outpatient clinic during COVID-19 with older community dwelling adults taught us that telehealth was essential. It was an essential treatment modality. Under COVID-19 quarantine procedures, many patients could not come to in-person visits. Our unique training includes rehabilitation of cardiopulmonary deficits of compromised individuals throughout the disease process or age spectrum. We can follow those post-COVID-19 or post-hospital admission patients via telehealth, especially for our patients in rural Kansas. You could also use telehealth to appropriately identify the best agencies to coordinate care with their home health, social services, and mental health support. APTA Kansas believes the best healthcare legislation policies are adopted based on qualified providers delivering evidence-based care that is safe and cost-effective. We understand our role in population and community health, not to mention the important role we play as experts in the treatment of musculoskeletal conditions. Our profession is uniquely qualified to help our patients with their musculoskeletal issues, and this can be done via telemedicine as well as in person. We play a vital role ensuring the safety and proper treatment of our patients in whatever modality is necessary based on our patients' needs and are ready and equipped to do so. Thank you all for your time today, and I can be available for questions after.
Thank you. Next I have Susie. Is it Turns or Turnus?
Turnus, like rhymes with furnace.
All right, with Speech Language Hearing Association. Welcome to committee.
Thank you so much. Thank you, Madam Chair and members of the committee for allowing us to testify today. My name is Susie Turnus. I'm the Executive Director of the Kansas Speech Language Hearing Association, and I'm a practicing audiologist at Ascension Via Christi in Wichita. What we are proposing today is an amendment to HB 2206, basically to include speech language pathologists and audiologists in the definition of healthcare provider. You may remember that the work we did back in 2018 when the original telemedicine bill came out, we were able to be added to the bill, but not under healthcare provider, but we were able to provide services to Medicaid recipients. And that has been especially helpful in schools. Little did we know when we were writing that bill that we would be having a pandemic and that schools would be forced to provide speech therapy through telemedicine, but that has worked out swimmingly. Students are doing well with speech therapy remotely, and we know that this modality works for our students. In addition to school children, of course, speech language pathologists and audiologists provide services in lots of settings, including hospitals. And during the pandemic, of course, some of the hospitals were shut down. And so people who needed these services were not able to receive them. In addition to hospitals, you have all these long-term care and nursing facilities, skilled nursing facilities that some of them actually closed their doors entirely, even to speech pathologists. So folks who needed speech therapy, those who were suffering from stroke or swallowing issues, were not able to receive services. So we're just asking that we be added under the definition of healthcare provider. We know that teletherapy works for speech, language, and hearing services. This has been a model we've used for a long time. Now it's time to move forward with the next step, which is adding us as healthcare provider. And I'm happy to answer any questions when the time is right. Thank you so much.
All right, thank you. Next I have Travis Euler, Executive Director of the Kansas Chiropractic Association. Welcome to committee.
Thank you, Madam Chair and members of the House Health and Services Committee. I appreciate the opportunity to provide neutral testimony on HB 2206. My name is Travis Euler. I am the Executive Director of the Kansas Chiropractic Association, representing over 1,100 licensed doctors of chiropractic and their patients. HB 2206 updates the Kansas Telemedicine Act under Chapter 40 of the KSA concerning insurance rules and coverage. We feel that the updates and changes made in HB 2206 are a good start. We are concerned, though, that HB 2206 as introduced can be read to define who can provide patient services via telemedicine instead of which provider types must be reimbursed by insurance for telemedicine services, as was the original intent of the Kansas Telemedicine Act in 2018. The Act currently has a narrow definition of healthcare provider, as you've heard previously already today, and HB 2206 does not update that definition. During COVID-19 pandemic, most provider types have pivoted to providing telemedicine when appropriate in order to reduce the potential of exposure to patients, providers, and staff. Over the last 12 months, we have seen that most provider types licensed by the Kansas Board of Healing Arts are able to safely provide healthcare services to Kansans through telehealth. And we contend that telemedicine is not a healthcare service, It's just a delivery method. It is a way of getting care to our patients, regardless of provider type. We asked that the committee amend HB 2206 to expand the definition of healthcare provider, not just to add doctors of chiropractic, but to include all providers licensed by the Kansas Board of Healing Arts when providing services within their scope of practice. Outside of this, we would agree with the Optometrics Association's statement that there is significant confusion about who can provide telemedicine services. Again, the Telemedicine Act is under Section 40, which is insurance, instead of 65, which is healthcare. So we'd like some clarification outside of an insurance regulation bill as to who can provide telemedicine services, regardless of the insurance situation or not. I thank you for your attention to this issue, and we'll stand for questions at the appropriate time.
Thank you, Travis. Next, we have David Jordan, President and CEO of United Methodist Health Ministry Fund.
Thank you, Madam Chair and members of the committee, for having me today. My name is David Jordan. I'm the President and CEO of the United Methodist Health Ministry Fund. We're a 35-year-old health philanthropy located in Hutchinson, Kansas. Our mission is to improve the health of Kansans, and one of our focus areas is access to care. We really work to try to make sure healthcare is sustainable for our rural communities. Telehealth has been a top priority for many of the groups that we work with for a number of years, so I appreciate the opportunity to testify today. While I'm not weighing in specifically on the bill as drafted, I did want to share some background research that the Health Fund has conducted over the last year, and some additional research that is in the works now as the committee and the legislature consider changes to telehealth policy. Last year, we worked with the state's provider groups, well, a number of the state's provider groups, to survey their members and to get feedback from providers and the providers sort of with experience treating patients on the telehealth experience. Largely, the experience and feedback that was generated through this survey was positive, recognizing that the use of telehealth increased significantly during the pandemic and the public health emergencies, and the policy results that made it easier to offer telehealth through different devices, as well as the increased reimbursement for telehealth. We saw a large jump in the number of providers utilizing telehealth. Of the respondents, 3/4 of respondents were using telehealth in a way that they hadn't been the previous year. The research highlighted that telehealth improved access to care for patients in both urban and rural settings. It increased the continuity of care. It decreased time away from work or from family so that they could see medical providers, and it allowed providers to better manage and contain healthcare costs. We largely see positive comments, which I've included in my testimony, from respondents of the polling. In terms of what the providers were doing, primary care and behavioral health were the two major categories of healthcare being delivered in Kansas via telehealth. And again, this was made possible as a result of a number of the policy changes. This was accelerated by the pandemic, clearly. Prior to those policy changes that went into effect at the state and federal level, nearly half of the respondents said payment for services was a major challenge. However, with the increased payment, you saw that 85% of the respondents indicated that telehealth was a positive option and they plan to continue it. However, just over 60% of providers indicate that as we think about what changes need to be made to telehealth policy, that payment parity is a top priority. Other policies highlighted as part of the study have also been highlighted earlier today, such as the ability to use audio devices, some greater flexibility in terms of privacy to ensure greater access for patients, and then some loosening of the rules around distance sites. Overall, we know this is just one piece of research. However, we are also in the midst of a more in-depth provider study right now, which should be completed in the next several months. And we are currently surveying Kansas consumers about their experience with telehealth, and we should be able to share that with members in the coming weeks. I'm happy to answer any questions, and I appreciate your time today. Thank you very much.
All right, thank you, David. Was there anyone else that thought they were listed as neutral and I have not called upon them?
Yes, Vicki Whitaker.
Oh, okay, Vicki.
Oh, good, I'm coming up. I will make my comments very brief, and I thank you. My name is Vicki Whitaker. I'm the Executive Director of the Kansas Association of Osteopathic Medicine. Thank you, Madam Chair and members of the committee, Vice Chair. Everybody has covered pretty much what I intended to cover as well. I would point out that I think it could be clearer if in the bill it says insert Kansas before the State Board of Healing Arts. I think everyone who practices medicine in Kansas should have to be licensed in Kansas. And I know with emergency orders that isn't the case. And my members feel strongly that anyone practicing in their state should be held accountable in their state. I also would like to see a broader, or KAOM would like to see a broader fleshing out of what is meant by using medical devices, because I'm not sure it's really clear. We would support allowing a physician to use the platform of their choice, because I am aware that some of my members have actually developed platforms to use for telemedicine. And we'd also like to see, I'm not sure what we'd like to see, but we would like to see a clear definition of who is allowed to use telemedicine, and if they are allowed and they're licensed, registered, or certified, then they should be held accountable to those licensing, certifying, or registering agencies in Kansas. Otherwise, it runs up against standard of care and possibly no recourse when there's a standard of care. Also in my testimony, I had put patients with complex medical needs, those with a need, and I messed that up. It should be those with a need for a diagnosis for unusual symptoms, and those needing medical testing need to be seen in person. I think it's very important to remember, yes, telemedicine has really helped everyone during this pandemic, but not all healthcare can be delivered via telemedicine and shouldn't be. And that concludes mine, and I'm ready to stand for questions when you have them, when appropriate. Thank you.
All right, thank you. Thank you, Vicki, and sorry for the oversight there. I think I just got a little excited with my pen and marked off a name quicker than I was supposed to.
I appreciate it. Thank you.
You're welcome. Is there anyone else that I have overlooked that thought they were signed up to testify on House Bill 2206? All right, committee, there is one written only testimony for neutral, and that's Brian Mills, President, Kansas Occupational Therapy Association. So I will now open it up to questions. And first I have Representative Parker, because he asked before you, Representative Epley. Yeah, I know you wrote your name down first, but Representative Parker.
Thank you, Madam Chair. My apologies, Mr. Vice Chair. I have a question, I think, for Audrey Dunkel, but Audrey, if you want to delegate this to anyone else, that's fine too. We've spent a lot of time thus far this session talking about mental health in this committee, and I wondered if you could expound a little bit on the effects of this legislation on being able to provide mental health to Kansans or services.
I'm probably not the right person as far as being the expert on mental health. I would certainly defer to our mental health representatives to talk about that. But certainly the flexibility and allowing people to access mental health either from our hospitals or elsewhere has been a significant benefit.
Thank you.
Someone else want to answer, add on to that? Michelle?
In answer to your question, I think one of the things that the pandemic has shown us is that The mental health centers have really been able to provide nearly all of the services they provide via telehealth. There are a few situations where it may not be appropriate in certain crisis situations or administration of certain types of medications. But in terms of therapy and treatment, they've been able to do almost anything effectively via telehealth. Over last summer, many of the centers also conducted customer satisfaction surveys. So they shared some of that with us. I think overall, not getting super specific with numbers, but you could almost divide it up into about thirds. A third of their patients who said, we actually prefer telehealth, and even when it feels safer to be back in person, we want to continue doing telehealth. About a third that said, we're really okay doing either way, and about a third that said when it's safe to be in person, we'd prefer to be in person.
Thank you, Madam Chair.
I might add one thing. I would agree with Michelle. I think it depends on there are folks that want the in-person. I would agree with that kind of that split. There's also the healthcare professional's judgment. Are you getting honesty? Are you getting the feedback you need? And those kind of things. It's part of the equation. I think one of the best examples that we heard from a real live person was one of our members in Emporia had a former patient who about the fall in the pandemic had started using again and had children that lived about 40 or 50 miles from Emporia and got home from work at 5 o'clock and would have had to leave her kids to make an appointment, and she didn't have broadband access. And so A, telemedicine, she could get services at home, and B, use her phone without visual communication to get service, which otherwise she would not have been able to access. So that's just one anecdote, but that's the kind of examples we're talking about.
Well, while we're on the topic of MH, I think one of the discussions at some point that has to occur in this is there is concern with some of our juvenile clients in the mental health and how often we would do that, and how not only them but others really need to still have that one-on-one, face-to-face in the room, so you can see all of the body language and see how they react in the entire environment. Would that be correct?
Yeah, I think that's correct. And, I think we've heard some of our child therapists in particular, when things were fully shut down, kind of really lamenting not having that direct eyes on the patient, or not being able to necessarily, especially with young minors, being able to speak with them purely in private. So I think, again, it kind of probably goes back to the therapist's not preference, expertise, and knowing whether telehealth is appropriate in that individual situation. But particularly in some of the situations that youth are in, it's often better if the therapist can see them face to face.
Thank you. Representative Epley.
Thank you very much, Madam Chair. And I guess I'm going to look to Chris, if you're still on with us. And so I guess being on the receiving end of telehealth and doing more visits in the last year than I've done in my entire career, and seeing the pros and cons of it and looking at the payment parity issue and having conversations the last day or so, I think there are a lot of details to this that maybe we need to consider and think about as we look at this bill. I'm all for this bill, but as we look at payment parity, from talking to mental health individuals, I can understand that this nearly meets all the criteria for a quality metrics visit, and you can measure that. It's very easy to measure in mental health, easier than I think in some of the medical specialties. And so, Chris, my long-winded question is to the point of metrics for measuring a quality outcome and trying to compare visits, i.e. in family medicine, cardiology, certain organ-specific specialties. When it comes to payment parity, what type of metrics are we supposed to use beyond time and patient satisfaction? Do you have any thoughts or ideas on that? Because I really struggled with quality visits as a primary care physician in my own telehealth visits. Thank you.
Yeah, great question. Appreciate that. I think in addition to the softer metrics on the patient satisfaction side that you mentioned, or more access to care, I'd highlight things that we would look at from a gaps in care perspective. So making sure that we are able to identify and have conversations with patients around being able to close a lot of those preventative care measures that, if they weren't able to make an in-person appointment, we're able to have the conversation to identify, say, for instance, a cancer screening that needed to occur because of the patient's age or risk factors. You think of a lot of the diabetic gap in care measures that we monitor in the primary and preventative care space. So I would point to a lot of those process metrics that we look at that in particular are related to preventative care metrics that we want to promote in any way we can, whether that's a virtual or an in-person visit. And then maybe secondly, from a delay in care standpoint, data is still a little early, but we're starting to see some of the indication of, especially in the heart attack and hypertension space, of what was the result of individuals who delayed maybe going to see their cardiologist or going to see their primary care physician during the pandemic, that if they had the ability to access more of a virtual care option, may have been able to identify some of those symptoms. So maybe not a direct typical quality metric you would have in the ambulatory environment, but more of an indirect one of a downstream impact of some of the data we're seeing on increased heart attack or hypertension. That I would qualify that data is still preliminary, and we need to understand more, and that'll come out here in the coming months as well.
Thank you again, Madam Chair. As we look at this issue of payment parity, I do think we should look, and this is maybe legislative research or to some proponent in the audience to advise us of how other states have handled payment parity, what models they've looked to, what metrics they've utilized, because I appreciate what we've been through the emergency orders, and I'm all for it. But as those orders fall off and as we get back to a more normal time, I think we need to have hard metrics on how we look at payment parity. And I think other states have had to deal with this, and I think we should look to those as examples as we look at rolling out payment parity. So that's just my only comment. Does any of the proponents have any input on that issue, since we're talking about payment parity so much, how other states have handled this, how they measure it in certain subspecialties of medicine? Thank you, Madam Chair.
Sorry, it's Chris again. I didn't know if there was anyone else who wanted to comment. I would note you tend to see more of the payment parity discussion reside in that preventative care from a metric standpoint. Preventative care, certainly mental and behavioral health, and chronic condition management. So the more complex patients we have, multiple chronic conditions, more likely to end up in higher acuity settings if they go without the access to care that they might otherwise get if they were able to make their in-person visits. So I'd highlight those three areas: mental behavioral health, preventative care, and the multiple chronic condition patients.
Okay, next I have Representative Lynn and then Representative Blex.
Thank you, Madam Chair. I have two separate questions, if I may. The first one was following up with what Representative Epley was asking about how many other states have payment parity. Specifically, I'm thinking about Missouri, given that I'm in the Kansas City area. I'm just curious. So I don't know if Audrey can speak to that.
Madam Chairman, both Missouri and Colorado have both payment and coverage parity as part of their legislation. And if I might go back to Representative Epley's question, I will have to go back and look at what metrics are there. As I've glanced over the statute, there are not statutory metrics for Missouri, but we can certainly come back with answers on that. Thank you, Madam Chairman.
All right, Representative Blex.
Thank you, Madam Chair. And mine is more of, I guess, a comment rather than a question. The pandemic has certainly provided us a unique evaluation period. We've had almost a year of some really strong testing. And my wife owns a small clinic with 6 employees, and we experienced COVID and had to shut down. And the telemedicine provision allowed us to keep the lights on and be able to pay employees. That was very important to us, and so I support it there. And another point that we might not think about, as an employer, it also allows an employee to stay at work in a private room or setting and conduct an appointment where he or she may not have to go home and change clothes and drive 25 miles. And my wife was in a situation where she would give an hour off at the evening just not to have the employee leave, which is a matter of convenience. So that's something that, as an employer, you don't, it's a benefit there, and a lot of the employees appreciated that too. So that's just my comment. Thank you, Madam Chair.
All right, next I have Representative Smith.
Madam Chair, Dr. Epley answered or asked my question, so I'm good.
That wasn't very nice of him, was it? Representative Kelly.
Thank you, Madam Chair. This question might be for Stuart, since you kind of headed the group to put this together, and it's got two pieces to it. Was there, I mean, we've heard come up a couple times on PTs, speech paths, audiologists. Was that considered at all in your discussions? I mean, those are being married to a speech path. I know that that telespeech is used, and by the number of job offers she gets, I know they're hard to find in rural areas. So I just wondered if that was discussed at all.
Well, no, I'm happy to. Thank you for the question. That make this, what you have in front of you as a whole, makes no judgment on anybody's capacity to do telemedicine. There were two, as we went through the conversation, and I think this is a function probably of the folks that participated in the survey. As I described them, they were either primary care or behavioral health providers for the most part. And so that was who was participating in the conversation. And when we got together and said, is there something that fits together, the issues that were complex and outside of the technical side of the existing law and the Telemedicine Act were who's a healthcare provider and payment parity. And so those were two things that were left out, because those are policy choices that you all have the pleasure and privilege to debate and make a decision on. And we wanted to make sure that at the very least some of these things that didn't impact any of those were at least in a bill, and there was something moving forward in that capacity. So no, not making any judgment on particularly some of those that are already covered in the Act. But everybody in our group is licensed, is regulated by either Board of Healing Arts or the Behavioral Sciences Regulatory Board. And that was just kind of the nature of who was there.
Okay, and the second part of the question, I haven't looked at everything that's in there, but I know that I came across a presentation from a provider in my district about 3 weeks ago on telemonitoring, and it's kind of a nursing home without walls, and they monitor patients to keep them out of nursing homes. So, I mean, some, of course, would be Medicaid, some would be private pay. Whether that type of service falls under a telemedicine service. I mean, there is interaction, but there's also monitoring to find out, are there changes in symptoms that would lead you to think that it may turn for the worse? And the goal is, of course, to save lots of money to keep some of these people out of the hospital and out of long-term care facilities.
Well, that sounds intriguing and useful, but I think that's outside of the scope of anything I should comment on. I don't think there's any, again, making no judgment based on what's in this bill, whether that should be in or out. There may be somebody else that wants to weigh in on that, but that's not necessarily my area.
Oh, no discussion on that?
No.
All right, and I believe we have Representative Ruiz online. And no, the Democrats didn't bring in an extra member. Everyone thought we were going to vote today, so they placed it, even though I did accuse Parker of doing that. But Representative Ruiz, are you with us?
I am. Thank you, Madam Chair.
There you are.
Yeah, I'm here. I think Stuart Little might be able to answer my questions.
Yes, hello.
Hi, Stuart. I had two questions. One was, did anyone in the group talk about voice only? I have heard from some folks regarding not being able to have a conversation with their physician just via phone. And these are folks who are older citizens and still use a landline. They don't have even a flip phone. Was there any talk about that and being able to include that in the bill?
Yes, and I appreciate the question. I know that that's come up a couple of times, and I think it arguably might be a point of conversation, but I would point out on the bill on page 1 on line beginning at the end of line 24, telemedicine shall be provided by means of real-time two-way interactive video, visual, or audio-visual communications. And so all three of those components are in the current law as is. I think and this is where we get into some federal conversations, and somebody from KDHE or KDADS may weigh in on this, but I think some of these policies are governed by CMS policy, and then what's come down from there in terms of essentially a waiver or flexibility on the video requirement as well. So I know there were some KMAP bulletins that came out that kind of set the framework for some of those. But in the bill, because originally when we submitted to your revisers the language, voice-only communication was part of it, then it was pointed out it's already in there on that line. Though it doesn't say it has to be any one of those, it can be any one of those three. But I think it may have been and again, this is one of the things, how do things change pre-COVID, post-COVID? It's become a norm, particularly for folks either in poverty that don't have broadband access, or rural that don't have broadband access, or elderly, or any of those is an issue.
Great, thank you so much. And my second question is regarding section 3, line 27. It's that whole section. Someone's already pointed out that section is a bit confusing. And as a clinical social worker, it feels to me like it might be singling out maybe mental health professions, and in possibly looking like there's a double standard there. Can you speak a little bit more to that section?
No, I'm happy to, and I appreciate the question. It's at the bottom of page 2, B3, beginning at line 27. And I'll tell you the reason this language is in here, and any of my colleagues who participated are happy to jump in. They'll probably let me do this on my own. But the conversation that took place was, to the extent that the use of telemedicine services in Kansas needed to be connected to, if you had a primary care physician, if you had a health home, if you had a care coordinator, if you were part of a system here in Kansas that was paying for your services and providing services, the incentive was not to participate without restraint in any telemedicine you may want to go participate in. And so the idea was, to the greatest extent possible, and this is rooted in some existing statute, the language here, the reviser used the existing statutory language, broadened it out, that if you are receiving telemedicine services to the best extent possible, those should be connected to either your primary care physician or your health home. And the intent is to not necessarily make anyone's doesn't address anyone's status or ability to license and diagnose or make a decision or anything. You don't have to get consent from a primary care physician, anything. It just says that care should be coordinated with the folks that are a part of that your healthcare system. And if you don't have a healthcare system, this wouldn't apply to you. You can go get the telemed you want. Does that make sense?
Yes, and as long as the patient consents, correct?
Right, absolutely.
Right. All right, thank you so much, Stuart.
Representative Lynn?
Thank you, Madam Chair. I have a question for Todd Fletcher. I was just wondering if you could provide some clarification on the healthcare provider boards and who will have that oversight.
Sure. I think part of the broader discussion is if other healthcare providers are included in the bill, that their appropriate agency have oversight over them. So I know there's been some discussions in other legislation around telemedicine waivers, but ultimately the providers were given permission to do it, but then the oversight came under the Board of Healing Arts, and it probably should follow the appropriate agency that regulates that board or regulates that provider, and make sure that that person follows the standards set by that provider.
Thank you, Madam Chair.
Representative Epley?
Thank you, Madam Chair. Second time, and I think this would be for Audrey. If she could come up to the mic, please. So just for the committee's understanding, try to help us understand maybe just one standard code of payment coverage versus payment parity as we're existing currently in the emergency orders versus how it was before those went into effect on a standard reimbursement, a 99213 or a standard office. The percentage difference. I think the committee, it would be helpful to the committee to understand the reimbursement differential.
Okay. I have no idea what those codes are. I am not a coder, but I think what you're asking, and it's something that we're actually trying to track down for you exactly what those differences are pre-COVID. So what would have happened prior to the emergency is that, say for an office visit, and this is how you had a negotiated rate for your office visit, or if you're a critical access hospital, it's a percentage of cost. If it was done via telemedicine, you were paid a different rate, different basis, whatever. As we went then into the pandemic, for the private providers, we're also seeing it in Medicaid, we're also seeing it in Medicare, that the in-person rate is now what's being paid. I think the question you're asking me is, well, if the office visit is paid at 80% of my charges, what am I being paid at the telemed rate? I can give you an estimate on the Medicare rate, because I just had this conversation with one of my small hospitals that said my clinic visit, I'm getting paid $267 for that visit in person, and I get paid $92 via Medicare, for Medicare via telemedicine. So that tells you a little bit about what happens with Medicare. Now, what you want is a comparison of the private payer, and we're working on getting that for you, what that actual differential is. Now, keep in mind, the amount paid is not the only thing you need to pay attention to, because if the amount paid is $10 less for a service that you provide 50 times a week, that is significant as something that's $500 less and you do once a week. So there are two measures of what you're looking at for that. And of course, in healthcare, things are adjusted along all of those parameters. Our Medicaid program does it every year when they set rates. They're budget neutral when they set rates, and they adjust.
Well, and thank you for attempting to answer that. I really get it and understand the complexities and the details of the codings and the different visits. But I think it would help the committee as we consider payment parity to know roughly, what rates were before COVID. And we now know that they're basically the same as they are if we saw the patient in person. And that's, I'm telling you, I know from absolute fact, that's a big difference. And I think it would be helpful for the committee's deliberations to know that information, at least in some general ways on certain examples in primary care, cardiology, gastroenterology, the standard visits of what the differential is, because I think it really will bear a lot on payment parity as we evaluate that. So thank you.
Thank you, sir.
Representative Bishop?
Thank you, Madam Chairman. Is the mic on?
Is the light on? All right.
Thank you. To my colleague and to the chairman, I appreciate the opportunity to ask what I hope is an extremely simple question. And looking at the regulatory picture and how it affects this issue, I'd like to know what is the regulatory arm for speech pathologists and audiologists?
What was the question again? I'm sorry, I got distracted. We were having little technical problems here. Please read.
Yes, ma'am. What is the regulatory board that regulates speech pathologists and audiologists? And I'm not sure who can answer that question, but that's an item of curiosity for myself. Is it the Board of Healing Arts? Is it the Behavioral Sciences Regulatory Board? Where does it fit into the regulatory picture?
Is Susie Turnus still on?
I am, yes.
Okay, there you go. We were trying
Yes.
to find your name. We just couldn't figure out where you were.
Yes, I had my hand up, but I don't know if anybody can see. Yes, so to answer your question, speech pathologists and audiologists are licensed and regulated by KDADs.
Thank you for the answer, and thank you, Madam Chairman.
You're welcome. Is there anyone else that has a question? All right. We kind of thought that when we introduced this and that we'd be able to at least move the ball forward on telehealth. And, just from the discussion we've had today and discussions that I've had since yesterday afternoon, the issue of rate parity is a lot more complicated than just a number. So it's not just the dollar amount that you have to take and look at. I was not here with this committee in 2018 when this was worked. So I can't even discuss with you exactly how that debate went on, what the details were. I know that the majority of this committee, I don't know if there was anyone that was indeed on that committee when it happened in 2018, Representative Barker and Representative Epley and Representative Kelly, Representative Berquist. So a decision will have to be made at some point whether we introduce a bill, and I'm kind of surprised that those that really wanted rate parity did not introduce a separate bill, because those that have requested it, talked about it today, know that it's a lot more complex than just saying, let's do rate parity and say that if you pay $100 for this service in a bricks and mortar, that you'll pay $100 on telehealth. I think you've also heard there's a little bit of complexity as to who should be in the bill, who should not be in the bill. We've heard conversation that perhaps it should be only those that are licensed through the Board of Healing Arts. We just heard that a couple of the folks that are wanting to be in here are not licensed through them. They're actually licensed through KDAD, so should they be omitted? Those are discussions that we have to have. So it was originally my intentions to work this bill either starting today or tomorrow, and my intentions are no longer to do that at this time. There will be a bill introduced to have the discussion on parity. Not sure if we'll have it ready this week. It will be our goal to have it, to get it out there, get it introduced, and then we can start having that discussion sometime in the future. There was a section that was in House Bill 2066 that was in Section M of that bill for the occupational licenses that Representative Croft and Representative Tarwater were kind enough to move over into this committee so it could be added to this bill. It dealt with telehealth. So that's another section that we'll have to look at on here. So if you wanted to look that up, you can pull up House Bill 2066 and look at Section M. I don't remember the page number because I walked out without the sheets that I had laying on my desk. That's what happens when you tell yourself you're paperless and you actually follow through with it when you should have paper with you. I would hope that we can advance the discussion of items that are in this bill that could be useful at this time, items that would be in Section M of 2066 that could be useful at this time, and then continue to have a discussion on rate parity. It would be my desire, for those of you that are familiar with me from around the State House, when it comes to complex issues in the area of health, I like to rely on the experts and not the legislators. We did this here a couple of years ago, and I know that she's real excited to hear me bring this up again, is on the corporate practice of medicine. All of the individuals got together. It wasn't easy, it wasn't simple, but they hammered out a solution. And in that bill, there was not one piece, not one word that was done by legislators, because the experts were at the table. That doesn't mean we can't add our own words to it, because we can. My preference on complex issues like this is to have the experts at the table. So I am going to strongly recommend at this point here that those experts start having that discussion. For those also that have been around the Capitol for a while, when I make that strong suggestion, it does not mean that you pretend you're having a meeting, or you pretend that you're having a discussion, or you refuse to come to the table, because this committee will, in fact, put together a bill if it's push comes to shove. And neither side, I guarantee you, will like whatever that bill is. I have successfully been able to function under these rules for a lot of years, and I think because of that, we have ended up with some excellent legislation, because everybody came to the table. Do we need a solution? Yes, we do, and we need it from both sides. Is there a compromise in there? I absolutely believe that there is. So it would be my intentions that at this time, we will not be planning on working House Bill 2206. And anyone that has questions or would like to discuss it with me further, you're welcome to do so, or with any of our committee members. But I suggest that the providers and the insurance companies come to the table, and that means all of them. So with that, committee, we are adjourned.